Good morning,
floor is yours.
everyone. Thank you. Good morning, everyone. And thank you for joining us for the Dental Board of California quarterly board meeting. My name is Joanne Pacheco, and I am the president of the board. Today is Friday, August 20th, 2021. This board meeting is being held via WebEx. Pursuant to the provisions of Governor Newsom's Executive Order N-08-21, dated June 11th, 2021, neither a public location nor teleconference locations are provided for this meeting. For all those who wish to participate, please log on to the WebEx website provided on the posted agenda for this meeting. Instructions to connect to the meeting are provided on the agenda. The preferred audio connection is via telephone conference and not the microphone and speakers on your computer. The phone number and access code will be provided as part of your connection to the meeting. Since this meeting is being conducted via WebEx, I will ask all board members and speakers to announce themselves by name before speaking for clarity of the official record. All board members are able to unmute themselves to speak during the meeting. Please place yourself back on mute when not speaking to reduce background noise for all participants. When making a motion, please use the raised hand feature located at the bottom right of the WebEx screen so board staff can identify a motion and a second. During a discussion on an agenda item, please use the raise hand feature if you want to speak, and I will call on you. Following such online meeting etiquette will ensure the best quality for everyone. During each call for comments from board members and speakers, we will ensure that all comments that can be accommodated are heard before proceeding with the agenda. The board will be taking a 15-minute break in the morning and a 30-minute lunch break estimated to occur between noon and 12:30 p.m. and another 15-minute break following in the afternoon. This is an official business meeting of the Dental Board of California. The board welcomes public comments on any item on the agenda, and it is the board's intent to ask for public comments prior to the board taking action on any agenda item. The DCA moderator will explain the process for providing public comment shortly. When called upon, the moderator will unmute the microphone of the individual and they will have 2 minutes to make public comment. The moderator will audibly announce when 30 seconds remain to conclude the public comment. After the 2 minutes have lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. Depending on the number of people who would like to testify on a particular agenda item, a total time limit may be imposed. We ask all speakers to please stay on topic and not repeat testimony already provided. If you agree with testimony already provided, please just state your name and that you are in support of any comments previously provided. I would now like to ask the DCA moderator to please explain how public comments will be taken during this WebEx meeting.
Thank you. This is the moderator. To facilitate public comment today, we will be utilizing the WebEx question and answer feature. You will hear me refer to it as the Q&A. When the board reaches a point in the agenda at which public comment is appropriate, the Q&A feature will be turned on and members of the public can indicate they would like to make a comment by clicking on the Q&A icon, which looks like a question mark inside of a square, typing the word comment into the text box and submitting that to the host. The text box will typically appear in the lower right of your screen. I will then call on the first individual and unmute their microphone. One of the new features in WebEx is that I cannot directly unmute your microphone. When I click on your microphone, it will send you a message at your end, allowing you to click a button that will pop up that says unmute me. When you click that button, that will then unmute your microphone. When you unmute your microphone, WebEx will make a brief statement at your end, so please pause for a moment to allow that statement to finish, and then you can begin speaking. Each commenter will have 2 minutes to make their comments, and at the conclusion of the 2 minutes, the individual's microphone will be muted, and I will move on to the next member of the public who has a comment. Please note that the question and answer feature is being used only as a means for the members of the public to represent that they would like to make a verbal comment. This is not a means to ask questions of myself or members of the board. Such inquiries submitted using this feature will not be answered. When making your comment, please make sure the comment is directed at the host in the dropdown. While you are free to express criticism or negative views, for the sake of members of the public participating on the call, please do not use profane language when making public comments to the board. I will provide a brief reminder of this approach at the start of each public comment item. And finally, when board members or senior staff are not speaking, I would like to remind them to mute their microphones. If I do detect background noise during the meeting as a result of unmuted microphones, I will either provide a brief friendly reminder to mute your microphone, or if it's not an opportune time in the meeting, I may mute your microphone myself. I also see that we have a few members in our public today that were not with us yesterday. As you may notice, we are using a new WebEx platform. And as you've probably seen, we do have live closed captioning. You should be able to see that on your screen. If you're on a computer, not sure about phones or tablets, but you can click on the closed captioning box and move it around your screen if you'd like to put it in a different location. You can also disable this if you do not want to see it on your screen. And you can do that by locating the closed captioning icon on your screen. There should be 2 icons closely together. One should look like a little robot and the other one is a little closed captioning icon. If you click on the closed captioning icon, it will hide the closed captions so they do not appear on the screen. If you decide after doing that you do want to see them, you can simply click that same button and they will reappear. You can also view the comments by comment by speaker. And to activate that, you can click on the little robot icon and tap on View Captions and Highlights. And that will open a panel that will allow you to watch the conversation, and it will be captioning it by who's speaking. And to turn that feature off, you can just follow those same steps. And as a reminder to our panelists today, the raised hand feature has moved, and you will locate your hand raise icon next to your names. And with that, I will turn it back over to President Pacheco.
Thank you. And before I call the meeting to order, I would like to acknowledge Dr. Jean Savage, who recently passed away. Dr. Savage had been a previous president of the Dental Board and the first female president of the Dental Board of California. We wish to send our deepest condolences to her family. And with that, I would like to call the meeting to order and ask the board secretary to please call the roll.
I will now call the roll. This is Dr. Alan Felsenfeld, Board Secretary. Burton.
Burton here.
Burton present. Chan. Chan present. Felsenfeld present. Laureen.
Laureen present.
Laureen present. McKenzie.
Mackenzie here.
McKenzie present. Medina. Medina present. Mendoza. Mendoza present. Molina.
Molina present.
Molina present. Montel.
Montel present.
Montel present. Morrow.
Morrow present.
Morrow present. Alagi. Alagi present. Pacheco.
Pacheco present.
Pacheco present. Stewart. Stewart present. You.
You present.
You present. Madam President, we have a quorum.
Thank you. We will now move on to agenda item 17, Dental Assisting Council Meeting Report. I will ask Jerry Fowler of the Dental Assisting Council to provide this report.
Jerry Fowler, Vice Chair of the Dental Assisting Council. And at yesterday's meeting, one of the first things we did is we approved the April 30th, 2021 meeting minutes. Then Mrs. Emily Zuluaga gave the following report updates. On the first report, agenda item number 4, there was an update on dental assisting educational programs and course applications and reevaluations. She also gave the update on dental assisting examination statistics for the RDA, the RDA-EF, the OA, and the DSA. Then she gave the update on dental assisting licensing statistics for the RDA, RDA-EF, the OA, and the DSA. Then we moved on to agenda item number 7, which was an update regarding administration of the RDA-EF examinations. With that, the RDA-EF examination, they were suspended in 2020 due to COVID pandemic during the last 14 months. They reached out to dental schools in both the Northern and Southern California to reserve a location to administer the clinical and practical examinations, but they were unsuccessful. However, in June of this year, the board was able to secure a contract with the Arthur Dugoni School of Dentistry, UOP, for the examinations. The RDA-EF clinical and practical examinations were administered by the board on July 31st, August 1st, August 14th, and August 15th in San Francisco. There was approximately 200 candidates in the queue for testing. All candidates were contacted and offered a space in the upcoming examinations. Many candidates decided not to test at this time and opted to see what happens with the Senate Bill 607. If signed by the governor, the legislation will go into effect January 1st, 2022, and the RDAF candidates for licensure will not be required to take the clinical or practical examinations. So the new RDAF written examination, on that one, hopefully it will be launched January 1st of 2022, which with the new RDA examination, it will incorporate additional content to measure competencies related to core retraction and final impressions that was previously measured by the practical and clinical examinations. Then we moved on to agenda item number 8, which is update regarding orthodontic assisting written examinations. And on that, the Department of Consumer Affairs, OPES, provided an overview of the occupational analysis process. Based on the basis of occupational analysis, the orthodontic assisting permit, OPS recommended that it be modified to adjust exam content by increasing the number of items from 65 scoreable and no pretest to 75 scoreable and 25 pretest questions, and increasing the time candidates have to take the exam from 90 minutes to 120. Additionally, since the number of candidates taking the OAP exam has substantially increased over the last 10 years, OPS recommended increasing the frequency of form change to help maintain the integrity of the examination process. And since the April meeting, the orthodontic assisting portion of the examination candidate manual was updated and will be available August 1st, 2021. And this exam is expected to launch on September 1st, 2021. And that completes the Dental Assisting Council update, the report. Thank you.
Thank you for your presentation. Are there any board member comments? Please use the raised hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to make a comment on this report, please click on the Q&A icon on your screen, type comment into the text box, and submit that to the host. Seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. We will now move on to agenda item 18, discussion and possible action on legislative proposal to amend Business and Professional Code, Section 1750, Infection Control Course Requirements for Unlicensed Dental Assistants. I will ask Ms. Amelia Zolaga, Manager of the Dental Assisting Unit, to provide this report and to present the action item.
Thank you, Board President Pacheco, and good morning, everyone. At the Dental Assisting Council meeting on April 30th this year, the Council discussed whether the infection control course requirements for unlicensed dental assistants should be amended to increase consumer protection. Board staff presented 4 options to amend the statute to change the timeframe of when the employer of a dental assistant must ensure the dental assistant successfully completes a board-approved 8-hour infection control course. Those 4 options are: 1, prior to performing any basic supportive dental procedures involving potential exposure to blood, saliva, or other potentially infectious materials; 2, within 30 days of employment; the third was within 90 days of employment; and the fourth was within 6 months of employment. After reviewing and discussing the 4 options, the Council took action to recommend the Board consider a legislative proposal to amend Business and Professions Code Section 1750, Subdivision C, to specify that the employer is responsible for ensuring a dental assistant has successfully completed a board-approved 8-hour course in infection control prior to performing any basic supportive dental procedures involving potential exposure to blood, saliva, and other potentially infectious materials. The proposed language is included in the meeting materials on pages 34 to 35 for the Board's consideration. Letters of support for this legislative proposal are enclosed on pages 36 to 51. The Board is asked to discuss and possibly approve the Council's legislative proposal to amend Business and Professions Code Section 1750, relating to infection control requirements for unlicensed dental assistants. If the Board approves the legislative proposal, the Board recommends directing staff to either submit the legislative proposal to the California State Legislature for inclusion in a future Healing Arts Omnibus Bill, or direct staff to include the legislative proposal as part of the Board's next Sunset Review report to be submitted in the Legislature in 2023. Thank you.
Thank you for your report. Are there any board member comments? Please use the raise hand feature. Dr. Chan?
Pacheco. In this era and time of COVID, this urgency of this requirement gives new meaning. Thank you.
Thank you, Doctor. Any other comments from board members? Is there a motion? Dr. Felsenfeld? Dr. Felsenfeld?
Much better if I unmute.
Oh,
right?
there you go.
Sorry about that. I make a motion that we accept the council's proposed legislative proposal to amend B&P Section 1750, and that we submit it to this proposal to the CSL, the legislature, right now for inclusion in a future Healing Arts Omnibus Bill, number 1.
And Dr. Yu? Dr. Yu, did you want? Thank you.
You second, yeah.
Thank you.
This is Executive Officer Karen Fisher. I'd just like to interject. In the event that it's not accepted as an omnibus bill, is it the proposer's recommendation to also include number 2 in the motion?
That would be me, Felsenfeld. Yes, certainly. I would hope we could put that in omnibus bill. I certainly agree with Dr. Chan, and the urgency of this is significant. So yes, if we cannot do it one way, let's do it the second way.
Okay, and the reason I'm bringing that up, we can submit the proposal, but it's up to the legislature to determine whether they think it's a non-controversial item. That's the key of an omnibus bill.
Okay, and
Okay.
one could make a good argument for controversial relative to these problems. Thank you.
Thank you for your comments. And Ms. Burton, I see your hand is raised.
Bring the amendment, Dr. Felsenfeld, to take out your comment about right now. We just want to submit this.
Thank
I
you.
have no problem. I have no problem with the sequence of how we do this procedurally. It just should go, and we should do number one.
Thank you.
Thank you. Are there any public comments?
This is Tara Welch. Could we get a clarification by Dr. Yu whether he seconds the amended motion?
Yes.
Thank you, Dr. Yu. So the DCA moderator, thank you.
This is the moderator. We've opened the Q&A panel. If you'd like to comment on this motion, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. First comment comes from Mary McCune. Mary, I've sent you a request to unmute your microphone. As a reminder, pause for a moment before speaking, and you will have 2 minutes.
Hi, good morning. This is Mary McCune with the California Dental Association. We just wanted to express our opposition to this specific legislative proposal, mainly because, in light of everything happening with COVID and even before that, there really was no, and it continues to be no evidence of actual transmission of any bloodborne or airborne pathogens. And really the purpose of the 8-hour infection control course was really to provide these unlicensed dental assistants with additional context, having them require to have this course completed before they're actually working substantially in a dental office doesn't really provide them with the background knowledge that would actually enable them to comprehend this. But really, the way that this was set up in the past was that you start and you have mentors and you have folks that are kind of teaching you along the way, and then over the course of learning those hands-on skills, then you complete the 8-hour infection control course that gives you the reasons for why you're doing things. And without that additional hands-on context, it really doesn't provide the reason why the petitioners are asking for this. It really needs to go hand in hand. And so we're happy to continue discussions around this about how this can be tweaked to really drill in what the petitioners are asking for. But as it stands right now and the way that it is presented right now, Cdca does continue to be in opposition. Thank you.
And thank you.
And our next comment comes from Melody Randolph. Melody, I've sent you a request to unmute your microphone.
I am representing CADAT, California Association of Dental Assisting Teachers, and the Dental Assisting Educators Group. In light of the current highly contagious and deadly pandemic, how can we ethically and morally refuse to tighten our infection control standards that could only help to slow the spread of disease transmission in California? The request here is simply to address the timeliness of the current requirement in infection control training. Is this really asking too much to ensure that the dental community is taking appropriate and responsible steps to protect the public from disease transmission? After all, this is our mission to protect and promote the health and safety of the consumers of the state of California. On a personal note, as an owner of approved certification courses, I take offense to the allegation by CDA in a letter dated August 10th to the Occupational Safety and Health Standards Board that my support of this timely change to the infection control course requirement is motivated by a personal agenda to increase the registrations for my course. This would be like saying dentists diagnose and treatment plan implants instead of flippers because they get paid more for the implant. In most cases, an implant is the better choice, despite the fact that they cost more, yet no one questions their integrity for treatment planning, the more expensive procedure. I believe my professional actions over the years should stand as personal testimony to the purity and sincerity of heart that I believe this change to the timeline of the infection control course requirement is a necessary change for the good of the consumers of California, not for my personal gain. Thank you.
And thank you.
Our next comment comes from Dr. Bruce Witcher. Dr. Witcher, I've sent you a request to unmute your microphone.
Hear me okay?
Yes, we can.
Okay, thank you. Yeah, I also would be in opposition to this, and I'm speaking on behalf of myself and also the California Dental Association. It remains that even though dentistry was deemed a high-risk occupation by the CDC and other agencies, occupational exposure in dental settings is reviewed and resulted in few, if any, reported cases of COVID. The ADA put out a survey in last year that indicated fewer than 1% of US dentists, and that's in the entire country, tested positive for COVID during 2020. So that is a surprisingly low number. In fact, it's lower than what's found among any other healthcare workers. These results really speak for themselves, and it's readily apparent that despite allegations of inadequate infection control training in dental offices, in the face of a highly contagious illness, that this training is in fact exceptional. Also, looking back at our past enforcement reports, I see that fewer than 1% of complaints received were related to allegations of unsafe and unsanitary conditions. So I really have to ask, what problem is this proposal supposed to resolve? I understand that there is heightened concern around infection control practices, but we already have a number of existing laws and requirements related to providing infection control training in dental offices. Dental offices are required already to perform annual OSHA and infection control training, document this in detail. They're also required to have an injury and illness prevention plan, a respiratory protection program, written bloodborne pathogens exposure control plan, and an office safety
30 seconds.
plan. So there's extensive documentation already required. In addition, information provided by board staff about the availability of courses, I think, needs further examination. There are no courses offered in my immediate area of the central coast of California, from Paso Robles down to Santa Maria. This requires us to send our prospective hires all the way to Fresno or Bakersfield and incur the additional cost of travel and accommodations overnight to take a course there. In addition, many of these course providers don't offer their courses to those outside of their program. And their course availability is going to be depending on building up enough enrollment to make it worth giving a course. So I think just to list a bunch of course providers for a given area may not tell the whole story. And I would suggest this be examined further because, once again, this is going to provide a barrier to entry into the workplace at a time of acute dental assisting shortage, with many of our assistants leaving the workforce.
Time is expired.
Okay, thank you.
And thank you for your comments.
Next comment comes from Claudia Pohl. Claudia, I've sent you a request to unmute your microphone. Oh, I see she rescinded her request for comment. Okay. Then with that, that concludes our request for comments at this time. Would you like me to close the panel?
Yes, please. And thank you.
It is closed.
And I see the hand up of board member Ms. Burton.
Is there any way, or is there anything, I don't know what the microphone connection is for the participants. The first two people I could not hear very well at all. It was very garbled. Dr. Witcher was very clear, but the first two speakers, I had no appreciation for what they said because it was so gargled. Is there anything that can be done?
Ms. Burton, unfortunately, sometimes that's what happens when the network connectivity at your end gets a little weak. I get that sometimes at my end as well. The only reason I know that it's still clearly coming through WebEx is because I can read the closed captioning. So it's a local issue at your end from what I can tell at this point.
Okay, thank you.
You're welcome.
Thank you, Ms. Burton. So we currently have a motion on the floor, Dr. Felsenfeld, seconded by Dr. Yu, to submit the legislative proposal to the California State Legislature for inclusion in a future Healing Arts Omnibus, and to include, number 2, direct staff to include the legislative proposal as part of the board's next sunset review report to be submitted to the legislature in 2023. And at this time, I would like to ask the board secretary to call the roll and record the votes.
I would be happy to do that. This is Dr. Felsenfeld, Ellen Felsenfeld, the board secretary, but I would like a point of clarification from staff or from Ms. Welsh. The original resolution was to approve the legislative proposal to B&P on that and to submit it to the legislature. Then the amendment was, if this is not possible, then to go to number 2. Is that my understanding? That's my understanding. Is that correct with staff and council?
Carol Welch.
Oh,
Go ahead, Karen.
First, I'm just going to say this was an obvious example of opposition, so this would likely not be accepted as an omnibus bill. So that's why staff essentially put the recommended motion forward. So while if the board votes to go ahead and submit it as an omnibus bill and it gets declined, then the next step is to include it in our sunset review report. And Tara, do you have anything to add to that?
I just wanted to clarify what the motion was. It was submit to the CSL, California State Legislature, for inclusion in an omnibus bill or included as part of the board's next sunset review.
Dr. Felsenfeld, are you clear?
I'm clear. It's not an or. It would be if my only concern is if the first one is accepted, then we push it that way. If it's not accepted, then we go to the second level. Because or means we have a choice at this point. Maybe our choice would be based on how it's received. I can live with that if everyone else can.
Okay, and President Pacheco, it looks like Member Olagi has her hand raised.
Yes, Ms. Olagi?
Just a little bit of clarification before we vote, if possible. As I'm reading this, so are we voting, because I read in there possibly 30 days, 60 days, 90 days, 6 months, that it will be changed or modified to versus the year. Is that going to be able to be discussed in future conversations by moving this forward today, or what does that look like? I'm just looking for a little bit of clarification there.
Good morning, Ms. Olagi. This is Sarah Wallace, Assistant Executive Officer. So the background memo that is provided in the meeting materials just provided a summary of the several proposals that were presented to the council at their meeting and what they had taken into consideration. Ultimately, the council had decided to move forward with the proposal to specify that the employer is responsible for ensuring a dental assistant has successfully completed a board-approved 8-hour course in infection control prior to performing the basic supportive dental procedures. And the language that the council approved and is recommending for the board to move forward with the legislative proposal is also included in the board meeting materials on page 34 and 35. So it's just the amendment requiring the course be taken by a dental assistant prior to performing the basic dental assisting procedures. Does that help clarify?
Yes, Sarah, thank you. Thank you so much.
Ready for the vote.
This is Board, excuse me, this is Board Secretary Felsenfeld. I will now take the vote on the proposed motion as we've been discussing. Burton.
Burton, aye.
Burton, aye. Chan.
Chan, aye.
Chan, aye. Felsenfeld, aye. Lareen. Lareen, aye. Mackenzie.
Mackenzie, yes.
Mackenzie, aye. Medina.
Medina, aye.
Medina, aye. Mendoza. Mendoza, aye. Molina.
Molina, aye.
Molina, aye. Montel.
Montel, aye.
Montel, aye. Morrow.
Morrow, aye.
Morrow, aye. Olagi. Abstain. Pacheco.
Pacheco, aye.
Pacheco, aye. Stewart.
Stewart, aye.
Stewart, aye. You, aye. We have a majority in favor, one abstention. The motion is adopted.
And thank you. We will now move on to agenda item 19, discussion regarding registered dental assistant in extended functions, administering local anesthesia and nitrous oxide, and merging RDA-EF scope of practice. I will ask Sarah Wallace, Assistant Executive Officer, to provide this report to present the action item. Sarah?
This is Sarah Wallace, Assistant Executive Officer at the Dental Board. This agenda item, just to clarify at the beginning, is to ask the board, sorry, my watch heard me, is to ask whether or not the board wants to move forward with conducting the research and to ask for assistance. For a point of background, in 2018, the Dental Board of California had received a request for an agenda item from a Ms. Joan Greenfield, part of the RDA-EF Association, asking the Dental Assisting Council to review a proposal regarding adding the administration of local anesthesia and nitrous oxide to the scope of practice for registered dental assistants and extended functions that were licensed on or after January 1st of 2010 as an optional post-licensure permit with conditions determined by the board. Ms. Greenfield had provided a survey that had been conducted amongst some of her students and licensees that had taken her course, as well as a proposed competency course that would need to be required in the proposal. We had asked the Office of Professional Examination Services to review that material prior to the November meeting, and they believed the survey was informative, but it was only providing the perspective of one group of RDA-EF. During the meeting, the council discussed whether or not it was necessary to add the administration of local anesthesia and nitrous oxide to the scope of practice for RDA-EF, and ultimately made a recommendation that the board conduct work groups and survey out RDA-EFs and licensed dentists and other interested stakeholders to research and evaluate the proposal in order to move forward a recommendation to the board for consideration. The board already has multiple certifications and permits that are issued. Just to clarify, the RDA-EF currently has two separate scopes of practice. There is a separate scope of practice for RDA-EF that were licensed prior to January 1st of 2010, and then there is a scope of practice for those licensed after January 1st of 2010. The part of the discussion was whether or not the multiple scopes of practice would cause confusion to the average consumer and make it difficult for dental employers to be able to track who was responsible for performing which scope of practice. And so the DAC also recommended that the board consider, as part of this survey and work group discussion, whether or not the scope of practice for RDA-EFs needed to be merged into one licensure category in the interest of consumer protection. At this point, board staff have researched on how to facilitate such a survey and work group to assess the opinions to be able to bring back to the council for consideration. Due to limited staff resources, work associated with carrying out our day-to-day responsibilities, and that the development of surveys and facilitation of work groups are not within our expertise, there has been no progress on this agenda item. After further evaluation, we've determined that in order to move forward with meeting the direction of the council that was given to facilitate this work group and conduct this survey, we would need the assistance of a board member to help determine whether or not a recommendation should be moved forward to the board. In your meeting materials today, I have provided a copy of the meeting materials that were provided to the Dental Assisting Council in November 2018 as a point of reference for background. In making a determination of whether or not the board wants to move forward, OPES has already recommended that the board would need to carefully consider factors involving the nature of the problem to be solved, to what extent the public's health and safety has been affected by the current requirement, to what extent implementing the change would impact consumers, how other states are regulating the profession, whether the benefit of the public would be significant enough to outweigh the cost to implement the regulations, how an applicant would be qualified, what type of examination would be required, what education and training would be required. Then the board would need to conduct more in-depth surveys to assess the proposal and put together work groups consisting of dentists, hygienists, RDIEFs, and other interested stakeholders to research and evaluate this proposal. So today, board staff is bringing this forth to the board for consideration for the following two factors. We're asking the board to determine whether or not it wants staff to conduct the in-depth survey of both the dentists and larger sample group of RDIEFs and conduct the work groups as recommended by the Dental Assisting Council. And then secondly, if the board does wish for this to move forward, staff requests a board member be appointed to assist staff with the facilitation of the surveys and the working groups. I'd be happy to answer any questions.
Are there any board member comments? Is there a motion on the floor at all on this action item?
So to clarify, the first request would be to take a motion as to whether or not the board wants to move forward with conducting the work involved with developing this proposal or not, to just stop with this recommendation from the council moving forward.
Are there any comments from the board members? Please use the raised hand feature. Dr. Montel?
Hi, yes, I just actually had a question. The proposal suggests a 50-hour competency course of instruction. Are we going to talk about that as far as where they came up with that and who decided on 50 hours competency?
Hi, Dr. Montel. So the 50-hour competency course was part of the proposal that was given to the board or to the Dental Assisting Council by Ms. Greenfield. At this point, staff has not evaluated the course content or made any determination as to whether or not it would affect or what the impact would be. That review process would be conducted as part of the survey and the working groups in order to move a recommendation back to the board. So at this point, all staff are asking is whether or not the board wants to move forward with researching whether or not to add the administration of local anesthesia and nitrous oxide to the scope of practice for RDIEF and review merging all of the scopes into one licensure category for RDIEF, or to leave everything alone for right now.
Okay, so I just have one more question. Can you hear me? So you talked about there was a difference between the 2010, before 2010 and after 2010 scopes, and now you want to add this extra addendum to it. So how do you merge, how would you go about merging those three scopes? What does that, can you just kind of clarify that?
Sure. That is correct. So there is one scope of practice for those ES that were licensed prior to 2010. And then there is another scope of practice for those licensed after 2010, which requires additional education and examination. At this point, Ms. Greenfield's proposal was to add this administration of local anesthesia and nitrous oxide as almost a permit that was added on to the EF. So similar to how a dental license would have a general anesthesia or conscious sedation permit. At this point, because of the different levels of scope of practice, the discussion at the council meeting was to combine the scope, and the working group would need to work with potentially the Office of Professional Examination Services and other experts on how best to work through that process and just make a determination to make a recommendation to the board. So that's essentially, we're asking for whether or not the board wants us to do the work involved with conducting the surveys and the working groups and the research that's required to make a recommendation to the board as to how scope of practice can be merged, what the course requirements would be, what the licensure requirements would be, and how it would impact consumers in the licensee category. So at this point, we don't have all of the details worked out. That's what we'll need to be working on moving forward, but we would need a board member's assistance in facilitating that process.
Okay, thanks. Thank you.
Thank you. Are there any other board member comments? Seeing none, are there any public comments? I'm sorry, moderator.
Go ahead.
Ms. Fisher, did I need to ask for a motion at this point? There were no other comments.
Well, Ms. Welch and I have been having a little conversation behind the scenes, and I would say if we have no motion, that essentially this item continues to not go anywhere. And Ms. Welch, if you want to comment too, and then the board can decide what to do.
Ms. Welch?
Welch, I agree with Ms. Fisher. You know, the record needs to reflect whether or not the board has determined there should or should not be further action on this item. You don't necessarily need a motion, but, you know, there should be discussion and a clear statement that the board does want to move forward or it does not want to move forward with this item. I think that if there's no motion to move forward, that's an indicator that the board doesn't want to continue action on this. But, you know, you need to state why.
And Ms. Burton?
I am not convinced of the necessity of this and going through all the steps and whatever expense would be involved in taking some action. I'm just not convinced that this is something that we need to go forward with on this time, which is the reason that I did not make a motion.
And Dr. Felsenfeld? Dr. Felsenfeld, did you have your hand raised?
Unmute, I'm sorry.
Thank
Anyway,
you.
I am opposed to this personally, but apparently if we don't put this onto the actual floor for a vote to say no, that we don't want to do this, then we haven't gone on record. theoretically, if we don't do anything, I think Ms. Fisher's absolutely correct, which is we're not doing anything. But I'm going to move that we do the study according to the recommendation, with the hopes that people will say no.
And Ms. Olagi.
I would second that. Not the no, but second the motion, not the last comment, in hopes that people would say no for clarity.
So the motion on the floor is to do the study, recommended, and seconded by Olagi. Are there any other board member comments? And Ms. McKenzie.
That, you know, I'd be supportive of a study, mostly because I think without that, I'm just not informed enough to make a decision whether to proceed or not proceed. And it was put forward by the, you know, the committee. So I want to be respectful of that, make sure we're making an informed decision.
Thank you. And Ms. Olagi, you had your hand raised.
Yeah, just to echo off what Ms. McKenzie says, you know, working chair side with multiple EFs and EF2s across, you know, California, from Northern California to Southern California, I do see the council's recommendation of validity for us to further explore this so we can make a data-based decision versus a thought or a feeling. Because I do see a lot of EFs, majority of the EFs and EF2s I work with are running their own column in practices. And I can see the benefit of this potentially being able to administer anesthetic when needed, when finishing or cementing a crown for a GP clinician. Thank you.
Thank you. And Dr. Morrow.
Dentist that employs RDA-EFs. I have, however, spoken with a few of our faculty members who do employ RDA-EFs and also some RDA-EF. And consistently, every one of them that I spoke to said that it is an issue regarding needing to refresh the local anesthesia for following the dentist procedures so that the EF could continue with his or her portion of the patient's treatment. So I think it is not necessary and important that we get additional information on how important and how much this is in need as far as our dentists and our RDA EFs, and also for the comfort of our patients.
Thank you, Dr. Morrow. Any other board member comments?
I had my hand up. I'm sorry. Can you not see it?
Probably not. This is Dr. Stewart. Dr. Stewart, yes, go ahead.
Yeah, I want to voice my support for Ms. Burton's thoughts. I have serious concerns about this issue, and I'm not in favor of moving forward on it. So I just wanted to make that clear. Thank you.
Thank you, Dr. Stewart. And Dr. Lorin.
Yes, I also have concerns. I know there's a need. But I don't think that training is enough. They would need a lot more training. At this time, I would oppose it. Sorry.
Thank you. And Dr. Morrow.
Oh, I'm sorry. I'm sorry, I forgot to lower my hand.
Well, there you go. Thank you. And Dr. Montel.
Yes, I mean, at first, just with looking at this one specific issue, I was opposed. But actually, if we're talking about getting more information, other states, how they're regulating the profession, that was on the list. To what extent the public's health and safety has been affected by the current situation, that's on the list. I think these are important things for the board to just understand basically about this, about the RDAF anyway. So unless it's going to be really cost prohibitive, I really think it's good for us to get informed in that respect. So maybe we could call it something different, but I do think that this would be important to look into. Thanks.
Thank you. And Dr. Molina.
How much this study would cost?
And Ms. Wallace?
We do not know the overall cost. We would need to put together a plan with a board member as to how to facilitate this survey and the work groups. And then we would develop a quote on what the study would cost.
Anything else, Dr. Molina?
Like roughly, you don't have like a rough idea how much these studies have been in the past?
Hi, Dr. Molina. We actually have not conducted such a study in the past, so no, we don't have an estimate of how much it would cost. At this time, according to discussions we've had with other experts, the Office of Professional Examination Services, in order to determine how to move forward, we would need a board member to help facilitate in this process. And so the purpose of today's agenda item was just to ask whether or not the board wanted us to move forward with doing this project. And if it did, we would need board member assistance. And so as more information becomes available, we would report back at future meetings. But there would be costs involved with facilitating surveys and work groups. At this time, I don't have an overall estimated cost.
Okay, thank you.
Any other board member comments? Dr. Morrow, you have your hand raised.
Yes, I would just like to add that the number one priority for the board is protection of the public. With that said, if obtaining information by the process of a survey is going to help us to make a decision regarding protection of the public, then it really we shouldn't be considered about how much the survey will cost. We need to be considering whether or not it's important as far as protection of the public is concerned.
Thank you, Dr. Morrow. Ms. Burton?
Want to point out that I do think that there is an obligation when someone brings forward a suggestion or a recommendation to have enough meat in it, to have enough detail in it to understand what it is we're being asked to look at. And that, in my opinion, has not been fulfilled. So we're going to study what? We're going to study something that has not been completely defined. It could be that this is necessary, but it could be also that it isn't. But this isn't definitive enough for me. So I still intend to vote no, because this is not as detailed as other things that have been brought to us to say, would you take a look at this?
Thank you, Ms. Burton. Any other comments? Dr. Loren?
With Fran about this, the study, are you saying that you're just going to ask if it's needed, or are you going to, what is going to be included in the study? Are you going to find out about the educational hours, the topics? What is going to be studied? Or is it just a survey? Do we need it?
And Ms. Wallace?
Hi, Dr. Loring.
Hi.
That's a good question. And so what I can respond with is that this proposal, the proposal and the meeting materials that you have in your board meeting package were given to the Dental Assisting Council in 2018. The council had discussion, but ultimately they also decided that they needed additional information. And so I think there's a lot of outstanding questions that need to be resolved. And that's part of the reason we've brought this back. So ultimately the council's direction at that meeting was for staff to conduct more in-depth surveys of both dentists and larger sample of RDA-EFs to assess their opinions on adding the administration of local anesthesia and nitrous oxide to the EF scope of practice, to form a working group consisting of dentists, hygienists, EFs, and other interested stakeholders to research and evaluate the proposal, and to recommend that the board consider exploring the possibility of eliminating the multiple layers of EF certifications by incorporating them all into one EF license. So at this point, staff also have a lot of questions. The only information we have so far is the proposal that had been brought forward at that Dental Assisting Council meeting. And so this would require, if we move forward with this, a board member to work with staff to essentially outline how we're going to facilitate this process and what questions we would address in order to bring back information to the board. So essentially, at this point, the proposal is asking the board to do the work to vet out whether or not it should be accepted and what the educational requirements would be.
Okay, well, I would be in favor of study, but right now, like Fran said, this is not ready for us to vote on. I don't think so. So thank you for your information.
Thank you, Dr. Loren. And Dr. Montel.
Should the board be the ones doing this preliminary investigative work? Is that something that we would normally do? I would feel like that would be done, and then that what I'm hearing is that they're asking us to do just a preliminary investigation to all the dentists to find out, is this a problem? That's what I'm hearing right now. Is that correct?
That is correct, Dr. Montel.
Is that normal procedure? Does anybody, I'm newer on the board, so is that normal procedure? I would think that people would bring this to us saying, this is the issue, you know, we need to do a deep dive. Are you guys okay with us doing a deep dive? That's what I would think we would get at that point.
And Ms. Wallace?
I'm sorry. I apologize.
No, go ahead.
I was just going to comment that from a staff's perspective, this is not typical. Usually if there's a proposal made by a stakeholder group that's considered by either the council or in most cases the board, the work is done by that group requesting the proposal, and it's not typically something that's requested of the board staff, but that is what the direction of the council was at this point for this particular item.
Executive Officer, I'd also like to jump in at this point just to let the board understand the enormity of this project. Somebody had asked what it's going to cost. It's going to cost a tremendous amount of staff resources, people working on this to move this forward. And I'm not suggesting that this isn't worth it, but I think the board needs to know if staff is going to be working on this project, as we go into sunset review, the board will need to prioritize what needs to be pushed to the side or hold off at a later date. So basically, that's what you should be considering as you decide whether to move this this issue forward at this time.
Are there any board member comments? Seeing none, so the motion on the floor is to perform the study with more in-depth surveys and form a working group. Seconded by Olagi. So at this point, are there any public comments? DCA moderator? Thank you.
This is the moderator. Our Q&A panel is open. If you'd like to comment, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. We have several comments already lined up. Our first comment comes from Claudia Pohl. And Claudia, I've sent you the request to unmute your microphone. As a reminder, you will have 2 minutes.
Thank you. This is Claudia Pohl with the California Dental Assistants Association, and we would just like to say that we would support exploring and gathering more data and information for the potential scope of practice change for the RDAEF. And if the board decides not to move forward with this, I would hope that the DAC would request in writing from the board, as allowed in BPC 1742, its reasoning for rejecting the recommendation. Thank you.
And our next comment comes from, I believe it's Sadie. I've sent you a request to unmute your microphone.
In alternative practice, and I was just curious if maybe they could possibly start off with a type of Orachix, non-penetrating. Maybe some agent like that can be utilized.
Thank you. And our next comment comes from Melody Randall. Melody, I've sent you the request to unmute your microphone.
Representing the California Dental Assisting Teachers Association, just speaking in support of this research. This has been a discussion for many years back and forth, and I do believe that there is a need for this procedure to be allowed to be done for the EFs, but I want to keep in mind and reiterate that there was a comment earlier about there's not enough training. Well, we don't even know what the training would consist yet. This motion on the floor is just to do that research to find out, you know, what would need to be done. And I would be in support of this procedure in the EF category and assume that the education and training would be equivalent to what hygienists get. I don't think the thought behind putting this into the EF category is anything but that same level of education and training. And there's no reason why an EF could not do that same level of education and training and be competent enough to provide this procedure to help the patients and the dental offices in California. Thank you.
Our next comment comes from Joan Greenfield. Joan, I've sent you the request to unmute your microphone.
Hi, this is Joan. Can you hear me?
Yes, we can.
All right, thank you very much. Very quickly, I feel like a lot of the information that has gone on for the last 7 or 8 years and presentations that have been done at the board on many and many occasions are being left out. We did do a comprehensive survey on the need for this and why and how often patients are being left waiting for additional anesthesia. That was presented at the board meeting several times, including in 2018. In regard to the 50 hours, someone mentioned that that was a comment in response to a specific area of the education that we were talking about several years ago. So no, we're not talking about a 50-hour class. And I would hope that you would move forward with additional research and information that you feel is necessary to move this forward. This is an important function. It should be a part of the scope of practice for the EF2. The reason that we proposed that it be post EF2 education is so that EF2 is the only portion of a dental assisting that does not allow for a work pathway and formal education at post-secondary level. The proposal that we have made in 2018 at a board meeting in Sacramento exceeds the educational requirements that hygiene uses, and specifically to nitrous oxide and local anesthesia. So we even did surveys across the nation as to what's required for hygienists on a national basis to do anesthesia in particular. And the proposal that we have come forward with exceeds those requirements. So I hope that you would at least move forward. We've been at this for 8 years, asking, bringing forward information, asking every single question you've ever asked of us, and presenting information far above anyone that has ever presented anything in front of you. One last comment in regard to multiple layers. There's only 2 layers, EF1 and EF2. And if you go back, I have requested this information in the past. How many EF1s actually still exist? People who have chosen not to become a 2, there are very few, so you don't exactly have multiple layers. We're simply asking to add some additional licensure to the EF2 who chose to do either anesthesia or nitrous oxide. You have dentists who have multiple layers and additional licenses, and that doesn't seem to be an issue for the board to handle. So I would ask you to at least move this forward. Do some good studies on your own since you don't trust ours. Thank you very much.
Are there any other public comments?
You hear me now?
Yes.
Okay, my apologies. My headset went out, I think. Our next comment comes from Arian Turlet. Arian, I'm trying to unmute. I've sent you a request to unmute your microphone. If you can click the unmute me button. All right, I will circle back. Let's move on to Dr. Bruce Witcher. Dr. Bruce Witcher, I've sent you the request to unmute.
Now?
Yes, we can hear you.
A few considerations. First of all, from what I understand from the proponent's suggestion, we're talking about 705 current RDA-EF2s that are licensed to perform restorative procedures where local anesthesia is most often needed to be given in addition. This is a very small number of licensees. And so if we're going to devote resources to expanding the scope of such a limited number, I would question the use of board resources to do this. This is not a new item, and you should go back and look because the Office of Professional Examination Services recently conducted an occupational analysis that indicated only 25 to 35% of RDA-EFs even do restorative procedures where the local might be needed. As far as the RDA-EF1s go, they're not going to be eligible because they're going to have to do the additional training to do restorative procedures where this might be necessary. And I guess I'm also concerned because the survey that was presented did not provide any information about administration of local anesthesia, nitrous oxide and oxygen. So I don't believe that is ready for study at all until further information is made available. The other point I'd like to make is RDA-EFs are not usually employed by safety net clinics because they command a premium salary, which is commensurate with their skills. Although they may be a positive addition to the dental workforce, there are just too few of them to have an impact on access to care. And then we have to consider also the cost of the training. If you add on another 50 hours to the training for the RDA-EF2 already, that's going to be significant. I would suggest the board might want to consider the assistance of OPES as they have a lot of experience putting together focus groups and survey studies. So since I don't think the board has either the time or the resources to do this, if they do want to move forward this, maybe perhaps they could enlist the aid of an outside agency. Thank you.
Our next comment comes from Anthony Lum. Anthony, I've sent you a request to unmute.
Can you hear me okay?
We can.
Awesome. Good morning, President Pacheco, board members, and DAC members. I'm Anthony Lund, the Dental Hygiene Board's Executive Officer. Since my board has not reviewed the issue, I have a general statement about this agenda item, since there's a comparison to dental hygienists in providing these dental services. Just some general information since the education aspect arose, but dental hygiene students are required to complete a complex, high-level college education and training prior to being deemed competent in their administration of both local anesthesia and nitrous oxide and oxygen analgesia. Their education is at least 4 years in length, when including the extensive biomedical prerequisite coursework in anatomy, physiology, chemistry, biochemistry, and microbiology, to name a few, and not just a few weeks or weekends to complete them. Then in the actual dental hygiene program, they must complete coursework in dental and dental hygiene science like head and neck anatomy, oral pathology, periodontology, it's a new one for me, pharmacology, pain management, clinical dental hygiene, dealing with special needs patients, etc., and those types of courses. I understand the intent of this proposal, but want to caution any approval of this request because local anesthesia and nitrous oxide administration are two very invasive, non-reversible, and potentially harmful procedures for the patient that take a lot of time, knowledge, and skill to administer appropriately and safely. Here's a quote from the 2016 ADA Dental Guidelines, and it says, "The curriculum in anxiety and pain control is a continuum of educational experiences that will extend over several years of the pre-doctoral program. It should provide the dental student with the knowledge and skills necessary to provide minimal sedation to alleviate anxiety and control pain without inducing detrimental physiological or psychological side effects. This holds true for the dental hygiene educational programs as well, as they're extensively educated and trained in their program for years prior to graduating." Thank you.
Our next comment, I'm going to circle back to Ariane Turlet. I've sent you a request to unmute your microphone. You should receive a pop-up with an unmute me button that you can click on.
Seconds.
Board members, if you stand by, we're having technical difficulties here with the moderator's microphone.
Yes, we are.
Okay, thank you. Ariane Turlet, I'm trying to unmute microphone. If you can please click the unmute me button. Okay, Ariane seems to be having some issues getting her microphone open. So Ariane, if you could type your comment into the comment box on the Q&A, I will read it aloud for you. In the meantime, Dr. David Gibson, I've sent a request to unmute your microphone.
Can you hear me okay?
Yes, we can hear you.
I actually have a group practice in I have a group practice in Livermore, California. We currently have 3 RDA EF2s, and we've had EF2s for multiple years now. And we do run into a lot of problems where, you know, the dental assistant's getting ready to pack the cord and needs to be numbed up a little bit more. And I got to break away from the procedure that I'm doing to, you know, go numb up the patient a little bit more. So I actually have multiple friends that weren't able to attend today just because they're working, but they have same thing as me, a lot of EF2s that work for them over the years or currently, and they run into some of the same positions. So our position is we'd actually like to have the board consider this because we think it would be a big beneficial thing for our EF2s to be able to do to help us out with our patient care. We do see a lot of RDAs that are actually interested in the EF2 programs, and right now there's a constriction to get in there. So I think it's going to be going forward a big thing where there's going to be a lot more EF2s that are part of our dental network going forward. So I think we should actually start looking towards the future and finding ways that these EF2s can support us a lot more. So that's my opinion and my experience and a lot of my friends' experience that we actually support the board moving ahead with considering doing some type of placement where the EF2s can actually be trained for local anesthetic administration. So thank you.
Thank you, and it looks like, my apologies, it looks like Ariane has a new connection, so we're going to try this again. So Ariana Turla,
Yes, can you hear me now?
Yes, it worked. Thank you.
Okay, sorry about that. I tried multiple times. Thank you very much. I appreciate all the attempts. So I actually speak in opposition to this scope expansion. I was on the state dental board during the EF2 expansion, and I was very much in support and continue to be in support of the EF2 duties that fell under the time that I was serving.
So Ariane, it appears we lost your audio connection mid-comment. I will resend the request. And to our legal counsel, Tara Welch, she appears to have lost her audio connection. Are you fine with me reading her comment?
Yes, this is Tara Welch. I think you should read her comment. That way we can get it into the record and everyone can at least hear what her concerns were. Thank you.
Okay. Her comment reads, I speak in opposition to this scope expansion. I was very intimately involved with the expansion of the EF2 duties. This was very well vetted at the time. The responsibility for the patients to be properly anesthetized, I'm not sure if I'm saying that word correctly, is the responsibility of the dentist.
Thank you, moderator. Are there any other public comments?
That looks like the last of them.
Thank you very much. With that, I'd like to ask the board secretary to please call the roll and record the votes for this agenda item.
Number 19, the motion is to study the RDAEF possibility of giving local anesthesia, all of number 1, as I understand it. Burton.
Burton, no.
Burton, no. Chan. Chan, no. Felsenfeld, no. Larine,
Yes.
Larine, aye. Mackenzie,
Yes.
Mackenzie, yes. Medina, Medina, aye. Mendoza,
Mendoza, no.
Mendoza, no. Molina,
Molina, no.
Molina, no. Montel, Montel, no. Morrow,
Aye.
Morrow, yes. Olagi,
Olagi, yes.
Olagi, yes. Pacheco, Pacheco, no. Stewart,
Stewart, no.
Stewart, no. You
No, you know.
know. We have 9 noes and 5 ayes. The motion is not adopted.
Thank you, Board Secretary. And this would be a great time for all of us to take a 15-minute break, coming back at 10:40. Thank you.
Wanted to do a quick mic check before we begin.
I can hear you. This is President Pacheco.
Oh, thank goodness. Thank you. My headset has been giving me all kinds of trouble today.
You did a good job. Welcome back, everyone. We will now move on to agenda item 20, Licensing, Certification, and Permits Committee Meeting Report. Discussion and possible action on committee recommendation regarding an application for conscious sedation permit. I will ask Dr. Stephen Chan, Chair of the committee, to provide this report and to present the action item.
Thank
Dr.
you.
Chan.
Thank you, President Pacheco. First of all, our hearts go out to the people in Northern California and the smoke that's enveloping you guys. In the Bay Area last night, the moon was orange. So our hearts go out to you guys up there. I'm Stephen Chan. I'm the chair of Licensing, Credentials, and Certification and Permits Committee. The committee met yesterday, August 19th, in closed session. We have a single case before us, and it's Dr. CS, who was issued a conscious sedation permit on January 1st, 1992. So in summary on the case, the board conducted an on-site inspection and evaluation on February 3rd, 2021, and the vote was split, with one recommending a pass and the second evaluator recommending a failure. The forms were submitted to a subject matter expert, and the recommendation from the subject matter expert was to fail the permittee. There was a second evaluation on April 21, 2021, and the vote again was split, with one evaluator passing and one evaluator failing. The recommendation was sent to the subject matter expert, and the recommendation from the subject matter expert was to fail the permittee. As a result of this, on June 7th, 2021, the petitioner was notified of the failure and the conscious sedation permit was suspended. So pursuant to California Code of Regulations, Title 16, Section 1043.6, 1646.4A, 1647.7A. The matter before the committee and the recommendation from the committee was the following. If an appellant has failed 2 evaluations, the board will decide the matter and may have one of 3 options. Number 1, grant the petition or grant the petition for the permit, deny the permit, or number 3, request further evaluation of the appellant with a board member or other board appointment appointed representative being present. The LCP committee debated and had a very robust debate on this. The committee will recommend to the board to deny the permit. So as the chair of LCP, can I move the motion on behalf of the committee to move that we deny the permit?
And we would ask Ms. Welsh.
This is Tara Welch, legal counsel. I would recommend that another member of the board make the motion.
I withdraw.
And at this time, are there board member comments? Dr. Molina? And is there a second?
Mendoza seconds.
And Mr. Mendoza. Okay, so there is a motion on the floor to deny the permit. First by Dr. Molina and seconded by Mr. Mendoza. At this point, are there any other board member comments? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
Opening the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on the screen, type comment into the text field, and submit that to the host. And President Pacheco, while we wait for comment submissions, I do know that we do have a couple more hand raises in our attendees or in our panelist list.
Thank you so much. Let's go ahead and take comment from Ms. Burton.
This is just a clarifying question. What recourse does this person have at this point? And if it's denied, is this something that at some point can be applied for again, or is there a number of times that you can be denied and then therefore not issued again? I just want to understand the process.
Excuse me. This is Executive Officer Fisher, and I'm going to ask Jessica Olney to respond.
Hi, good morning, Jessica Olney. Typically in these cases that we've had before the closed session, when the board moves to accept, we will get in contact with the permit holder. The permit holder has the option to apply for a new permit. At that point, we would require that the permit holder, or excuse me, the applicant at that point would be reevaluated and pass an evaluation before we will issue a permit. Does that answer your question, Ms. Burton?
Jessica, did you say at the beginning, if the board moves to accept?
Correct. This is a recommendation from the committee.
But if the board moves to deny, what happens?
No. So the board would be moving to accept the committee recommendation to deny the permit. The current permit holder the permit is suspended. So if the board moves forward, the permit holder will be notified that the board denied his permit. And if he would like to reapply, he would go down that path. He would reapply, pay all the fees, and go through another evaluation. Is that helpful?
Yes.
Thank you.
Are there any other board member comments? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
Q&A panel has been open and we've received no requests for comments.
Thank you. Then we will repeat the motion, which is to accept the committee's recommendation to deny the permit. And we will ask the board secretary to now call the roll.
This is Dr. Felsenfeld, Board Secretary, on the motion as stated by Ms. Pacheco. Burton. Burton, aye. Chan.
Chan, I to deny.
Chan, aye. Felsenfeld, aye. Loreen.
Lorraine, aye.
Aye for Loreen. Mackenzie. Ms. Mackenzie?
Yes.
Mackenzie, aye. Medina. Medina, aye. Mendoza.
Mendoza, aye.
Mendoza, aye. Molina. Molina, aye. Montel.
Montel, aye.
Montel, aye. Morrow. Morrow, aye. Olagi.
Olagi, aye.
Olagi, aye. Pacheco. Pacheco, aye. Stewart.
Stewart, aye.
Stewart, aye. You.
You, aye.
You, aye. The vote is unanimous. The motion is adopted.
Thank you.
This is Steve, the chair. I want to thank the members of LCP for some very insightful discussion.
Thank you, Dr. Chan. We will now move on to agenda item 21, enforcement, review of statistics and trends. I will ask Carlos Alvarez, Chief of Enforcement Field Offices, to present this agenda item.
Good morning, President Pacheco, board members. Carlos Alvarez. I'll be presenting agenda item 21, enforcement statistics. We'll start off with the complaint and compliance unit. For the fourth quarter, April 1st, 2021 through June 30th of 2021, the complaint and compliance unit received 1,145 complaints during this time frame. Compared to the last quarter to this quarter, we received 105 more complaints. So the monthly average of complaints received was 381 complaints. Currently right now, with complaints cases that are open in the unit, there are 706 complaint cases that are open. And in the bottom of the tables, you'll see the aging of the cases here. So currently right now, from 0 to 3 months, we have 522 cases pending. 3 to 6 months, we have 111 cases pending. 6 through 12 months, we have 72 cases are pending. And the 1 year complaints, we have currently 1 case that is pending. And so currently right now, what we're doing is we're waiting to receive records. Once the complaint compliance unit receives a complaint, they enter it in the system. The staff starts requesting records from the subject or any subsequent treating dentist, or we're waiting on more documentations from the complainant. And so that's part of the process there with the complaint and compliance unit with the open cases. And I'll move on to the number of cases closed within the unit. We closed out 732 cases. Again, these cases are closed because they're being reviewed by our dental consultants. Our dental consultants are reviewing the complaint. The dental records that we received from the subjects, from the treating dentist or any subsequent treating dentist, they review it. They opine that there's no errors, so therefore we close the case out. Also, cases that are closed, what we refer to non-juris, where some of the types where the complaints are just requesting a refund. We don't have the authority to request any refunds. Those type of natures of the cases that we close out. I'll be moving on to the cases of investigations with subsequent arrest reports that we received from the Department of Justice. We receive these reports once a licensee gets fingerprinted. We get notifications from the Department of Justice that they've been fingerprinted for a criminal action. So automatically in the investigative analysis unit, we start ordering court documents. We start ordering police reports. And also some of these cases are pending because we're waiting on final disposition of the criminal hearings. So once we get final dispositions of that criminal hearing, then that's when the board starts taking action to move it forward to an investigation. And so some of these cases that we're awaiting could take months, it could take years, depending on the type of crime, and again, just waiting on the final disposition. And the breakdown on our next page, on page 3, is the breakdown of the cases that are currently pending for SARS, subsequent arrest. And currently right now, 0 to 3 months, we have 74 cases that are pending. 3 to 6 months, we have 48 cases that are pending. 6 to 12 months, we have 66 cases that are pending. 1 to 2 years, we have 54 cases. And 2 years, we have 16. And again, the reason is because we're waiting on the final disposition from the courts. And I apologize, there is a typo there on our little graph there. It shows 250, but really we have 258 cases. So currently right now, with the number of SAR cases that we closed between the fourth quarter, we closed out 87 SAR cases. And now when we close out those cases, it's either because there was an arrest, but it turned into a detention only. There is no criminal actions filed, so we'll close that out. The district attorney declined to file any charges. There's a lack of sufficient evidence, or the court dismisses the case for further justice. So therefore, we close out the case and we don't take any action on those type of cases. And then I'll move on to the number of investigative cases that are open in our investigative analysis unit. Currently, there are 577 cases that are open with our investigative analysis unit. Then in the bottom, we have the breakdowns. So we have 0 to 3 months, we have 13 cases that are pending. 3 to 6 months, we have 42 cases. 6 to 12 months, we have 109 cases that are pending. 1 to 2 years, we have 260 cases. 2 to 3 years, we have 150. And we have 3 cases that are pending at 3 years. And now our statute of limitation is 3 years, and we're constantly monitoring our statute of limitations cases. And we make those a priority, and that's with all of our units. And that's with our investigative analysis unit. That's with our sworn investigators unit. We're constantly monitoring these statute of limitations, and we make these priority. And I'll move on to the number of investigative cases open in our Sacramento field office, which is our sworn investigators. And currently right now, we have 201 cases that are pending. And I apologize, our graph right there just didn't capture everything on the graph. So in the graph from 0 to 3 months, we have 46 cases that are pending. 3 to 6 months, we have 31 cases that are pending. 6 to 12 months, we have 42 cases that are pending. 1 to 2 years, 48. 2 to 3, we have 29. And we have cases for 3 years, we have 5 cases, so that's relatively low. Again, we make those priorities. And with the sworn, some of these cases that the statute of limitations can expand is because it's either fraud, and fraud cases are very complicated because there's just a number of years of records that we got to collect. We got to collect records from the dental insurance companies, and so those take some time. So those just come to examples of some of the cases that would extend our statute of limitations. And then I'll be moving to our number of investigative cases open in the Orange field office, and that's with our sworn investigators. Currently in our Orange office, we have 366 cases that are pending. So 0 to 3 months, we have 40 cases. 3 to 6 months, we have 42 cases. 6 to 12, we have 87 cases. 1 to 2 years, we have 125. 2 to 3 years, we have 63. And at the 3-year mark, we have 9 cases that are pending. And I'll move on to the number of cases that are open in our Orange field office with our non-sworn investigators. So currently, right now, we have 137 cases that are pending. In the graphs, we have 0 to 3 months, we have 22 cases pending. 3 to 6 months, we have 21. 6 to 12 months, we have 40. 1 to 2 years, we have 31. 2 to 3 years, we have 20. And our 3-year marks, we have it at 3. So total cases, again, 137. So now the number of investigations cases that were closed, and this is combined with all of our units. That's the investigative analysis unit, our sworn investigators, Sacramento and Orange, and our non-sworn in Orange. And we closed out 179 cases. So when we close out these cases, again, these cases move forward to an expert. An expert could opine that there is no errors. Some of these cases that we closed out because there was just no evidence that violations occurred within our Dental Practice Act. So those cases are closed out. And I'll move on to number of inspections. Currently right now between the 2 offices of Sacramento and Orange, we have 139 inspections. We have, in Sacramento, we have 30 cases, and our Orange field office currently right now has 109 inspections. Now I'll move on to the number of probation cases that we have open. So currently right now we have 171 total probationers. 155 are active probationers, and we have 16 that are tolling. And so what that means with our tollers, what it means that they're out of state, they're not practicing in the state of California, so therefore their time doesn't count towards the reduction of time in their probation. But they still have to comply with terms of their conditions. They still have to comply and check in with our probation monitors quarterly. So there's still terms that they have to follow, but just their time does not count towards the reduction of their time. So currently right now, with our investigative analysis unit, there are 21 active probationers. We have 3 probationers that are tolling. Our Sacramento field office with our sworn, we have 24 active probationers, 8 that are tolling. And our Orange field office, we have 110 active probationers, and we have 5 that are tolling. Move on to citations, administrative citations that we issued for the 4th quarter. We issued 14 citations. Examples of some of these citations that we'll issue is either because the treating dentist had bad record keeping, so we'll issue a citation for that, and that's after an investigation, after it's gone through an expert and a dental consultant, and they deem that they had poor record keeping. So since there's no patient harm, we issue a citation. Another example for issuing a citation is where the subject dentist or any subsequent treating dentist have not responded to the board's request for patient records, and they don't send in the patient records within the 15 days, we'll issue a citation. So those are some of the examples that we'll issue citations. So I'll move on to accusations. So between the 4th quarter of April 1st, 2021 and June 30th of 2021, there were 33 accusations that were filed with the Office of the Attorney General's office. Cases assigned to the Office of the Attorney General, there was 40 cases that we transmitted to the Office of the Attorney General. And currently right now at the Office of the Attorney General, we have 115 cases that are pending. This concludes my report for enforcement statistics.
Thank you, Mr. Alvarez. Are there any board member comments? Please use the raised hand feature. And the first one is Ms. Burton.
Hi, Carlos. Would you give us some examples of typical SARS cases?
Sure. Yeah, I'll give you some samples of the subsequent arrest. I would say the majority are driving under the influence. I think those are the majorities that we get. It's either a licensee, dentist, RDA, driving under the influence. We also get SARS for battery, misdemeanor battery. And then we do get cases of domestic violence. I would say those are kind of our top three type of cases that we get. There's anomalies. There's just very, very few that we get felonies for assault with a deadly weapons. But the top three, I would say, would be a driving under the influence, simple battery, and domestic violence.
Thank you.
Thank you, Ms. Burton. And Dr. Chan.
This is Dr. Chan. Good morning, Carlos.
Good morning, Dr. Chan.
I have a question on the probation cases where do you see trends of the probation cases, not just the numbers, but since in probation there's a wide range of conditions which consumes time. And as we see these numbers, it may not reflect the amount of time that is consumed by our staff on there. What are you seeing for trends?
And so just to get kind of overall, what we do is with all of our probation cases, we do conduct audits with all of our supervisors. Supervisors, they meet with their staff. They bring all their files in. They go over all the probation notes, each file, and they identify if there's any issues with those probationers. So once they identify those issues, what they do is our supervisors prepare a report for our executive team, which is with Karen Fisher, Sarah Wallace, Tina Valerie, Bernal Balba, myself. And we review these cases because, again, we want to make sure that all these probationers are compliant and they're within their terms. Some of the things that we saw during COVID was some were having issues paying monitoring costs, cost recovery, because either there was a reduction in their employment and working hours, or they weren't working. So those were some of the things that we kind of noticed. So what we do is we put a plan of action again, get together. They have to request with us to the board if they want to amend their cost recovery, and we move forward with that. We submit it to the AG's office, or we can make recommendations here with the dental board. But these were some of the things that we encountered during COVID. But again, we're always conducting case audits, and we're always identifying if there's any issues with these probationers.
So some of the time consumption for the staff is also looking at some of the conditions that you're tracking. For example, the remedial education, the monitoring of drug abuse. So that consumes time too.
Yes, that consumes time because, like I said, what we do is we also did have deadlines for the probationers as well, that they have to send us documentation, like I said, that they're in compliance. So every quarter they have to send us in compliance reports. We have to make sure that they're sending their probation costs, their monitoring costs. We have to go in on our system, on our brief system, review everything, reviewing the files. And again, just constantly staying apart. If we're given deadlines, we have to stay on top of the deadlines that are coming in and making sure that we don't miss those deadlines. So it is kind of time consuming, but it counts time management as well. So the investigators have to have properly time management in order for them to review their cases and probation cases.
Thank you for your work, Carlos, and thank your team for their work.
Thank you.
Thank you, Dr. Chan. Are there any other board member comments? Seeing none. Are there any public comments? Oh, I'm going to back up a little bit. Dr. Morrow raised his hand. Dr. Morrow?
A little late on the response there. Carlos, I appreciate your report and the good work that you do. Just for purposes of refreshing my memory and maybe other memories of the other board members and possibly some of the new ones, could you explain what is the difference between sworn and non-sworn? And also, what are the factors that are making it necessary to extend closing of the case for up to as much as more than 3 years.
Okay, with our sworn investigators, we've been to a police academy. We've been trained in the laws of California. We have the authority to make arrests. We have the authority to write search warrants. We have the authority to file criminal charges with the district attorney's office. But at the same time, we have the authority to file cases administratively with the Attorney General's office. And so with our non-sworn investigators, they don't have any peace officer powers, so therefore the investigations they conduct is strictly administrative compared to the sworn investigators.
And what you're saying is depending on the type of offense is which one you would be assigning that case to.
Correct. Depending, and like the more serious cases, again, with the SARS, that would, if it's a serious felony, that would get assigned to a peace officer. Allegations of fraud, criminal fraud, that would get assigned to a sworn investigator. Because again, if the investigation leads that there is criminal action, there was fraud, we present those cases to the Attorney General. To the District Attorney's office, but at the same time, we file administrative.
Okay, in addition, the second half of my question was, what are the factors that are projecting the length of the time to close the case to as much as 3 years or more?
Yeah, so with those cases that extend to 3 years or more, again, it's the fraud cases. The majority of all of our cases that kind of extend over the 3 years is all fraud. So when we're getting complaints from consumers, we also get complaints from the insurance companies as well. They send us all their documents reporting that there's been some fraudulent activity. They send us all their patient records. And again, that takes time because we actually, when they report this, there's usually, I would say, about 50 patients plus. It goes into 100 patients at times. So it takes time to carefully review each patient record, how much they billed for, and the services that they treated, reviewing x-rays. So those take some time, and that would extend our 3-year limitation. And the majority is fraud.
Okay, thank you very much.
Thank you, Dr. Morrow. Are there any other board member comments? Seeing none, DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. We have a request from Dr. Bruce Witcher. Dr. Witcher, I've sent the request to unmute your microphone.
Thank you, Dr. Bruce Witcher. Again, speaking for myself, the report is interesting because it appears that cases are accumulating in the investigative analysis unit. As I recall, that the IAU was not, we didn't always have that, and it was implemented to provide an additional layer of review of cases, which was a good thing in that it helps move them forward and make sure they're thorough. But I can see that because of the time it takes, they may be accumulating there and causing more of a case backlog. Of course, we are continuing to see cases accumulate at the AG's office, and that's been going on for a long time, and we do what we can, I think, to help the AG with getting cases well prepared before they're sent over. It would also be interesting, and I think previous board members have also requested this, to see if there's any complaints related to COVID-19 transmission in dental offices. So far, we have not really heard very much about this. It may be that they're all going to Department of Public Health and being dealt with there, but it's hard to believe there wouldn't be at least some coming forward through the dental board complaint process. And that, you know, if there are in fact cases of this type, it might provide additional justification for infection control review, such as was proposed. And if there is no evidence, then I would question the need for that. Thank you.
And seeing no additional requests for comment, would you like me to close the panel? It is closed.
And thank you. We will now move on to agenda item 22A, Diversion Program Report and Statistics. I will ask Bernal Vaba, Chief of Regulatory Compliance and Discipline, to present this agenda item.
Good morning. My name is Bernie Baba. I am the Chief of Regulatory Compliance and Discipline for the board. I will be presenting agenda item 22A, the Diversion Program Report and Statistics. The memo provides the statistics through June 30th, 2021. The statistics reflect the participant activity within the diversion program. In June, we received 1 new participant and 9 participants remain in the diversion program. Of the 9 participants, 4 are self-referred, 4 are probation referred, and 1 enforcement referral. The next diversion meeting is scheduled for October 20th, 2021, and I'd be happy to answer any questions you might have.
Are there any board member comments? Dr. Chan.
Good morning, Mr. Baba. This is Steve Chan.
Morning.
Earlier in my first term, we had a member from the diversion committee give testimony before the board. It was very, very compelling. It put a face on what kind of work you guys are doing. We might consider, as the board continues to turn over, to invite someone again to put a face on the work that you're doing. Thank you.
Thank you very much. I will look into that for you.
Thank you, Dr. Chan. Are there any other board member comments? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've again opened the Q&A panel. If you'd like to comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. And seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. We will now move on to agenda item 22B, Controlled Substance Utilization Review and Evaluation System. I will ask Mr. Alvarez to present this agenda item.
Pacheco, I'll be presenting agenda item 22, our CARES report. So currently right now we have 34,992 active licensed dentists as of June 30th of 2021. And with the number of registered DDSs or DMDs, currently right now we have 16,422. Compared to our last quarter until now, we have 128 new licensees that registered with CARES. So currently right now for the CARES usage, as of June of 2021, April was 15,542, in May 17,402, in June 18,993. So again, that's good news that the system is being used with the searches. And what this includes is individual dental offices, but also it includes where these dental corporations, where they have more than one office and they're using the same database, they're using the same credentials. And so it's all together with individual and with these corporations that have more than one office that they're sharing the system. Times that the system was active. April, it was active 4,000. May, 3,639. And in June, 3,896. And with the help desk, this includes telephone calls and emails for death inquiries. So in April, there was 173 inquiries. In May, there was 152 inquiries. And in June, there's 168 inquiries. And now below, number of prescriptions filled by schedule, they reported 2 through 5, and that accounts for all licensees in the state of California. So there's 12 types of licensees, and that is reported with the totals of all the prescriptions that are being written. And this also includes paper prescriptions, e-scripts, faxes, and telephone calls. This concludes my report on cures.
Thank you, Mr. Alvarez. Are there any board member comments? Dr. Morrow.
Thank you, Carlos. Again, a good report. I have a question. We have a number of dentists that have licenses in California, but they also have licenses in other states as well. And they have kept that California license active even though they're not physically practicing in the state. Do we get any information regarding cures data on those licensees?
On on licensees out of state, I believe there is a portion of it that is reported out of state pharmacists. So out of state pharmacists do have to report, but with out of state licensees, we don't have any information on that.
Thank you. Maybe we should look into it.
We could reach out to our liaison and, of course, and get information on that.
Thank you, Dr. Morrow. Dr. Chan?
It's Dr. Chan again. 2 questions. We have, since it's kind of still early in the development of cures, we have the ingress of the numbers of users as well as registered users. And then do we also, would it be of value to gather statistics on people that drop out of the cures by dropping out of or surrendering their DEA? That's the first question.
Yeah, so in order to get that data, again, that would have to be done through our Department of Consumer Affairs liaison, and also meeting with Cures stakeholders. And I kind of go back from the last time too, because I did check in, was to present on the total number of prescriptions, if they could break it down by licensees. So with your request and the other requests, I did look into it, and that would have to take a meeting with their Cures stakeholders to make that request.
Thank you, Carlos. The second question is, would there be value of characterizing the users on frequency of use based on time in practice? How long have they been in practice? Would that be of value to us?
I could see a value to that, and again, is gathering those statistics. But again, since we don't manage the Cure system, we have to go through Department of Justice and Cures to make those type of requests.
Thank you, Carlos.
Thank you, Dr. Chan. And Dr. Lorin?
Thank you for your report. I had a question.
Good morning.
Good morning. I had a question last meeting about the e-script capability of connecting with Cures database to automatically report, which would be excellent. And also the question about e-scripts. Can we prescribe narcotics through e-script? I don't know if you were able to find that out.
Yeah, for e-scripts, you could prescribe via e-scripts, and that's for scheduled controlled substance 2 through 5.
You can.
So yes, you can.
Okay. And the other one, a question?
And the other question, I'm sorry, if you could repeat it one more time, I apologize.
If e-script, when you make a prescription through e-script, is it capable of reporting to the cures database? So we won't have to go back in there and report manually.
Yeah, yeah. So once it gets reported to via an e-script, whoever dispenses the controlled substance has to report it. So if they dispense, it shall be reported as soon as reasonably possible, but not more than 1 working day after the date a controlled substance is released to the patient or representative. So whoever dispenses it reports it.
Has to report it separately manually. The e-script is not capable of doing that when you do it, when you prescribe. The e-script is it like the company that provides the e-script or the app or whatever you use, the program that you use for e-script, is that program capable of connecting directly to cures? I mean, do you have any information if that's a possibility to do that through the e-script program?
Yeah, that I don't know, but like I said, it does get reported. An e-script does get reported to cures, whoever dispenses the controlled substance. That does get reported.
Automatically.
But I'm not sure about, like you said, using the app or anything like that. But I can find out for you.
Okay, yeah, please. I mean, I just want to try to avoid a step. If the e-script is capable of, you're able to prescribe on the internet through an e-script. I mean, I think it would be able to automatically connect with the database of cures, and you don't have to do that second step. It's a lot of work, for the staff and the dentist to go back there and have to report every time the cures. So it would really save a step.
I can find out for you.
Thank you.
Thank you, Dr. Loren. Are there any other board member comments? Seeing none, are there any public comments? DC Moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. And seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. And Dr. Loren, I still see your hand raised. Okay, thank you. We will now move on to agenda item 23A, update regarding merger of Commission on Dental Competency Assessment, Cdca, and the Western Regional Examining Board, Rev. I will ask Sarah Wallace, Assistant Executive Officer, to provide the report on this agenda item. Sarah?
In June, the Dental Board of California received notification that the Western Regional Examining Board and the Commission on Dental Competency Assessment were intending to combine into one organization. This new entity will be known as the Cdca Rev, and together the merged entity will administer the ADEX examination, which is accepted in 49 states, the District of Columbia, Jamaica, and Puerto Rico as the basis for initial licensure for dentists and dental hygienists. The transition to fully operationalize this merger is expected to go on through 2022, during which time both the ADEX and Rev examinations will be administered. And then beginning with the class of 2023, only the ADEX examination will be administered. Currently in California, applicants for a dentist license may apply for licensure by taking either the clinical and written examination administered by Rev within the prior 5 years to the application, or the clinical and written examination that is administered by ADEX within 5 years prior to the date of application. Board staff has consulted with the Department of Consumer Affairs, Office of Professional Examination Services, and legal counsel to determine whether or not any statutory changes would need to be made. At this point, we believe current statute is sufficient and no additional changes would need to be made via the legislative process. Everything would need to be implemented on the back end with the office. So we anticipate a smooth transition at this point. There is no action as a result of this. And I do know that Dr. Morrow had attended the July 2021 Rev Dental Exam Review Board meeting, and I wanted to ask if he had any comments to provide regarding that report.
Dr. Morrow?
Yes, thank you. That was a very interesting meeting where the board, the two organizations discussed their merger. Basically, it is a joint commission now, rather than competing with each other, you might say, for examinees. It'll be all the same exam. The ADEX exam, the Rev exam, obviously will not be administered any longer. And it is also interesting that the ADEX exam will now be the closest that we have to a universal licensing examination in the United States, in that it is accepted by 49 of the 50 states. I think Rhode Island is the only one that it isn't accepted in. But anyway, it was an interesting meeting and discussion, how that it was actually Rev that initiated the conversation, that with ADEX, I understand, that eventually resulted in the joining hands together with those two written or regional examinations. So that's about was the extent of the meeting. It was more a discussion of how this came about and how it will be administered in the future. So,
Thank you, Dr. Morrow. Are there any other board member comments? Dr. Chan.
This is Dr. Chan. Among the directions that these two agencies are doing to construct the examination is two things. Number one, yes, it's about a performance of the procedures, but even more importantly, they are constructing their examinations on the premise that judgment and decision-making is just as important. And that's consistent with our role to protect the public in terms of how they decide and what they decide to do. Thank you.
Thank you, Dr. Chan. Are there any other board member comments? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
I had my hand up.
I saw a hand go up and then I saw a hand go down. And
Yes, this is Dr. Molina.
Okay, Dr. Molina.
Yes, so we had a training a couple of days ago on the merger, and more than anything, what I really feel that is going to be protecting the consumer is the fact that it's going to be using a mannequin and not a live subject. So not only is going to be standardized, but it's also going to be safer for the public, since they're not using a patient but a mannequin. So if they make mistakes, it's going to be on a mannequin typodont. Thank you.
Thank you, Doctor. Are there any other board member comments? Okay, we will move to public comments. DCA moderator, please facilitate the lines for public comment.
This is the moderator. I've opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen, type comment into the text field, and submit that to the host. Our first comment comes from Sadie. I've sent you a request to unmute your microphone. She seems to be having some issues with the unmuting of the microphone. She did post a comment. The comment is, this will be beneficial for participants who are in the military and move from state to state. And that was the only request we received. Would you like me to close the panel?
Yes, please.
It is closed.
And thank you. We will now move on to agenda item 23B, which makes sense that we will combine with agenda item 23C. Therefore, I will ask Dr. Bruce Horn, Director of the Rev, Dr. Guy Champagne, Vice President of the ADEX, and Dr. William Pappas, President of ADEX, to provide the report on this agenda item.
Good morning to all the board members. Thank you for the opportunity to present to you this morning. I will keep this brief. If you recall, in May of this year, I gave a rather complete presentation of the procedures in detail that the Rev examination is comprised of, and that's still available for board members to see at any time. I think it'd be redundant for me to go over that again. As far as the Rev examination for 2022, there are no changes, no content or administrative changes to the examination. It'll be the same examination that was offered and administered and implemented last year. Of course, both a non-patient simulation examination and the patient format for operative and periodontics will be available to candidates. On-site retakes certainly are possible on the following day, on the final day, for candidates that qualify. Next slide, please. And again, just as a refresher, there are 5 sections to the Rev examination. The written section, or the OSCE section, if you will, is described as the comprehensive treatment planning. That's given at a Prometric center. Certainly, we are still including prosthodontics, endodontics, periodontics, and operative dentistry. I would like to say that real quickly, and thank you, President Pacheco, for also giving us the opportunity to speak. This merger really provides for a benefit to all of our stakeholders. That includes the candidates, the schools, the boards, and certainly the educators. A single national clinical exam, universally accepted by all state dental boards, it truly is, as Dr. Morrow said, a national exam. I think New York and Delaware are, Delaware certainly gives its own exam, and New York is a PGY1 state, so I think that's how we come up with 49. I'm not certain about Rhode Island. This also gives educators an opportunity to prepare their students to challenge a single examination and to provide valid results to state dental boards that are defensible for applicants that are demonstrating successful psychomotor skills, knowledge, and ability for the safe entry-level practice and independent practice in the clinical setting. And I think that is the charge of state dental boards in protecting the public. I will yield the rest of my time to Dr. Champagne to present, and also Bill to present on the ADEX, please. Thank you.
Could we have the next slide, please? This is Dr. William Pappas, President of ADEX. There we go. Thank you. On August 3rd, 2021, the Cdca General Assembly met and proffered final support in the form of a unanimous vote in favor of the Cdca Rev merger. We welcome Rev to the ADEX family as the newly formed Cdca Rev. Next slide, please. Even before the Cdca Rev merger, ADEX had achieved coast-to-coast acceptance, as you will see from the upcoming image. The competent use in the restorative examination will be expanded in 2022 with additional carious lesions requiring the candidate to diagnose the teeth to be restored. In addition, the non-patient competent is joined by the most ethical patient-based examination option, the PCCIF. These exams are coupled with the longest-running, continuously improved OSCE in dentistry, the DSE OSCE. With new item types, which have been thoroughly psychometrically evaluated before release into the wild, the DSE OSCE is the most advanced computer-based examination in dentistry today. Could I have the next slide, please? As the map shows and as it has been discussed, the ADEX examination is already accepted in every state in the United States, which accepts an independent third-party clinical licensure examination. The exceptions that have been mentioned are New York, which accepts no examinations and licenses by postgraduate residency, and Delaware, which gives its own state licensure exam. Next slide, please. Rev will continue to offer their examination, as been mentioned, in 2022 to fulfill commitments made to students who have already begun that pathway to licensure, and to implement adequate training for their examiners and implementation of systems for proper delivery of the ADEX dental examinations. By the beginning of 2023, the ADEX exam will be offered in every dental school in the United States, Puerto Rico, and the U.S. Virgin Islands. This establishes an undisputed national licensure examination in dentistry, much like the USMLE in medicine. A broader examination affords greater resources for further refinement and development of new technologies, such as the Competent. Next slide, please. For dental schools and their students, this means preparing for only one examination and not diverting valuable time and resources for multiple licensure examinations. This also means less disruption of clinic time for both school and student. True portability of dental licensure will be realized with one examination offered and accepted throughout the United States and its territories. Next slide, please. For dental boards, this means, as has been mentioned, one examination series as in medicine. Boards will have immediate access to all examination attempts throughout the United States via the web and our secure servers. This means complete access to both the DSE OSCE and the clinical licensure exams, whether successful or unsuccessful. Next slide, please. The examination, like other licensure examinations in various disciplines, identifies individuals who do not perform acceptably. It is not a process to rank or certify individuals. The ADEX examination is pass-fail. It is a component in the process state boards use to determine who will receive licensure. Dr. Champagne, would you like to elaborate on that?
Yeah, I think that that is one of the most important concepts we have here. A licensure exam is not meant to determine who should receive a license. It's meant to identify the very small numbers of people who get through any process, because no process is perfect, and to identify who is not ready for a license. And with that, you want me to move on to the next slide?
You bet.
Okay, so I want to, it's what I'm going to try to be as very efficient as possible and really fill you in now that we do have a national examination process of which California is a critical part. The philosophy we're using to develop examinations in the future, why we do what we do, and equally important to tell you how our simulations are performing. One of the things, though, I want to address is some of the criticisms of the process. And one of the most common criticisms is predictive value. And so all boards are being told now that clinical licensure exams have no predictive value. It's going to surprise you to hear that we don't disagree, because that's not what they're intended to do. There's no way to do that. We can't construct an exam like the SAT
because of ethical issues. We can't give licenses to people who fail it. We can't give licenses to people who don't go to dental school. We cannot test the premise, whether it's medicine pilots or this, what will happen if we didn't do it. The assumption is that if we don't do, if someone is unable to perform now, they're not going to be able to perform in the future. Next slide. Then another criticism we have is this is just a single encounter and it's not fair, and that feels unfair, but the reality is for a patient, it's their treatment. And every high stakes performance, whether it's a pilot, a neurosurgeon, or a dentist, or a dental hygienist, or any other licensed individual with a high stakes license, it is the treatment, and patients expect that every time it's going to be performed competently, not an accumulation of averages. Next slide. If this really is in concert with the slide that you saw Dr. Horn present, the content of the ADEX and Rev exams really test the same skill sets because it's based on an occupational analysis. It's not based on somebody's opinion. All of us, in fact, we have the same required skill sets. Next slide. There is no debate that an OSCE is required. The ADEX exam contains the oldest continuously maintained OSCE in dentistry in the world, and Rev has the second oldest continuously maintained OSCEs. We find that judgment is a vital thing that we have to evaluate, and understanding of clinical relevance, medical evaluation of a patient, etc. The exams have been progressed to state-of-the-art with alternative item types, constructed response, and the future is only brighter as we can coalesce those two talents together. Next slide. But the reality is all of the literature that we could review shows that cognitive tests will not predict clinical performance. In fact, I would challenge anybody asserting that to present the evidence-based review to us as scientists, showing there are cognitive tests that can predict clinical performance, because we haven't seen that. Next slide. This just gives you, and I'm not going to belabor the statistics on this, a lot of this is for your reference. You can refer to it later, but these are pass rates of each of the components of the exam, because people will commonly ask, what's the cumulative pass rate? Well, the reality is, if you look at these are separate cohorts. So there's very little correlation between these cohorts. In other words, people who are unable to pass the OSCE are not the same cohort with endodontics or prosthodontics or even restorative dentistry. It seems that internal preparations, hand skills, and external preparation, psychomotor skills are something different. So if you look at that over time, you're going to see that we have about a 1 3/4% ultimate failure rate. That corresponds very positively with most high stakes licensure exams. Next slide. This really is to show you the performance of our simulated exam. Actually by standardizing the challenge and increasing the number of clinical dilemmas that they're going to have to evaluate for a candidate, it appears that the simulated exams are actually more discriminating of issues than even patient-based exams, because we can increase that variability. Next slide. And statistically, and this is just again for reference, I'm not going to belabor it, but we provided statistics between patients and simulated both in restorative. Next slide. Prosthodontics. Next slide. Endodontics. Next slide. So you have statistics, if you wanted to look at them, about what the issues we're identifying are. What are the clinical deficiencies? And the wonderful thing about our simulated exam, through the modification process, we can test the application of judgment into a clinical outcome. Now, we went through this with you prior. The fact that in last year, because of COVID, about 50% of our candidates were graduates of dental school. They were not dental students, they were dentists that had passed all competencies, passed an OSCE, passed the national board. I'm going to just ask you to just race through these slides. I'm not going to comment on them, but these are just examples. If you want to look at it, and you can just keep pressing forward down the road. If you want to see the type of work we're identifying, because the question becomes, when you see this work, is it significant? Should we do a psychomotor exam at all? Is that important that these are dentists that felt that this work was either the best they could do or was appropriate? And that's really the issue. It seems to me, and we can stop here, and this is the philosophy behind 8X and the test constructors, that when you see work like that, that's the reason we have to do this. In fact, now that we have really transformed 95% of all the exams given this year in dentistry and dental hygiene were non-patient simulated exams. Now that we have really addressed the issue of the ethics when patients are forced to participate in exams, and we can give a challenging exam, and we can evaluate whether someone can translate their judgment into care, which is the only thing a patient goes to a dentist for, why would we not want to know that information? What's the downside of knowing that information? Would we ever eliminate it for pilots? Would we eliminate the performance part of CPR, ACLS? I know as me as a patient, of course not, because I know the first question I'll ask the neurosurgeon or cardiac surgeon when my loved one or I need care, it's how many have you done and what were your outcomes? Next slide. So when we see these types of errors, this is what's driving the development of our examinations in the future, to identify the clinical situations that are critical for the success or failure of dental treatment. Now that we will have the same exam given in every dental school in the United States beginning January 1st, 2023, now that we'll have one exam to prepare for, and universal portability, and a non-patient alternative, I think we have entered a new era in dentistry. And with that, I don't want to use any more of your time, and we'll be happy to answer your questions.
Thank you, doctors, for your presentation. Are there any board member comments? And Dr. Montel.
Regarding the list of just areas in the test, can you just speak maybe to where we see coverage of pediatric dentistry and maybe why we don't see a clinical piece on that?
Yeah, that's a great question. So I'll try to address it first. And of course, Dr. Pappas and Dr. Horn can fill in. What we test is based on an occupational analysis of what entry-level dentists do. Now, we do test pediatric dentistry in our OSCE,
right,
because it seems that entry-level dentists in their first 5 years of practice don't perform pediatric dentistry. They evaluate and refer to pediatric dentists. So we do address the cognitive issues that an entry-level dentist would do in evaluating pediatric patient, or even some of the procedures they might perform. But if it doesn't make the cut score, we can't do it. I'll give you an example. We thought this year with the occupational analysis, or when we did it a couple of years ago, that a 3-unit bridge would not make the cut score, that implants have replaced it. We found out that entry-level dentists don't do that. So we cannot add a procedure that entry-level dentists don't do because it doesn't protect the public to test somebody on something they're not going to do. We have to use the time to test on what they are going to do.
Well, don't you think they're going to do it eventually? I mean,
yes.
there is a population, a huge population of children out there that these are the future of who's going to treat those children, right? So or maybe you can answer why you're just testing them on what they're only going to do just out of school.
You're absolutely correct. There is no question that you're correct. But the philosophy in licensure testing, and in differentiation to a certification. So for example, board certification, I'm an OMS, that's a totally different process. That's to certify somebody's competence. So when initial licensure, we expect the practice to evolve and improve over time, and the part of the construct is continuing education requirements that the dentist might do to enhance their practice. So You're right, dentists will eventually perform that. Dentists eventually perform implants and cosmetic procedures like Botox and other things. It's just that the testing construct, so in other words, the principles of test development, don't allow us to test things that are not done in the first 5 years of practice. It's a testing principle across all licensure tests, not just ours.
No, I understand that. I mean, for me, I just like to comment that as a board member, and especially as a public health board member, I personally see many dentists coming out, and we have in the safety net a ton of kids, and we're trying to, and we get on a majority new dentists who are very, very uncomfortable treating children. And so I just want to know where that's happening. If we're not going to test it on the way out, then I guess we have to step back and say, what are they getting before that? Because we just don't want to have people learning on the job, as they go out, learning when we're dealing with an entire giant population. Well, we need to look out for our patients, which is, there's a lot of kid patients. So that's all I'm saying. That's the only comment I want to make. But thank you.
Thank you, Dr. Montel. Dr. Morrow?
Dr. Horn and Dr. Champagne for spending your time and being with us today. I do want to admit my error. It is not Rhode Island, but it is Delaware that still offers its own licensing examination. And I want to make sure that Rhode Island doesn't come after me for that, okay? Secondly, I was wondering, are you still going to be offering your patient-centered curriculum integrated format for the ADEX exam?
Yes, we have to, because there are still 3 states that require a patient-based exam. So those really account for the 5% of candidates that took our patient-based exam last year because they were planning to attend or to get licensed in one of those 3 states. Once that situation disappears, my belief is you will not see patient-based exams in dentistry or dental hygiene.
Okay, so in other words, the curriculum integrated format is the only patient-based exam that you will be giving.
Correct.
Okay, thank you very much. Appreciate it.
Thank you, Dr. Morrow. Any other board member comments? And Ms. Medina?
Yes, I just want to thank you all for this presentation. As a public board member, I really appreciate the standardization and the continuity and the testing. So good job and thank you.
Thank you, Ms. Medina. Any other board member comments? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to make a comment on this item, please click on the Q&A icon on your screen, type comment into the text box, and submit that to the host. Our first comment comes from Dr. Bruce Witcher. Dr. Witcher, I've sent you a request to unmute your microphone.
We have a lot of acronyms being used here, and I hope I'm not the only one who's a little bit confused by this, but my understanding is the board earlier moved to have OPES review the dental licensure OSCE that is being proposed by the Joint Commission on Dental Examinations. If that happens, we could potentially still have 2 licensure pathways in California, one being this combined Rev ADEX examination, which has already been approved, that has an OSCE element. But we could also end up with the JNCDE's OSCE as well. So just a comment there. Thank you.
And seeing no additional requests, would you like me to close the panel?
Yes, please. And at this time, I would like to compliment all of the board members as you have mastered the raise hand feature. So with that, we will take a 30-minute lunch break, resuming back at 12:30. Thank you.